Yakima Valley Community College Radiologic Sciences Program presents Radiographic Positioning. Thoracic Spine.
Demonstrate a thoracic spine. First of all, the patient is dressed just like they would for a chest. They're in a gown without any underwear or jewelry on. Patient is lying down on the table. They're straight. And I like to ask the patient, the knees don't have to be bent, but it's a courtesy. Would you be more comfortable with your knees bent?
Yeah.
Okay, and I think the camera can still see with her knees bent. Most patients will prefer their knees bent. It's just more comfortable for them. And you can think of a thoracic spine just like a chest. The film's edge is 2 inches above the shoulder. I have my tube at 40 inches. It's transversely centered. Film's edge 2 inches above the shoulder. 14 by 17, ID to the top. Notice my R marker. It's moved in a little ways because I'm going to collimate. I'm going to put the MSP to the center of the film. My tube is lined up with the film, so I can just float my tabletop from this point forward. And I'm going to get the MSP to the center. I can put my hands on the angle of her ribs and find the xiphoid process, and I'm very happy with that. Collimation is the 17, and depending on your hospital philosophy, you're going to see survey type work with, here's the ribs, just within the rib cage, to more of an orthopedic philosophy with tight collimation. And of course, the tighter the collimation, the more you'll move your marker in. I put it basically in an average amount, but if I had that tight a collimation, I'd move that marker in even a little more. Okay? And most of the time your hospital work, so it's just skimming the ribs. Okay. I have the pillow up away from the shoulders. She's not rotated, both arms to her side. You can elevate the chin if you think it's down in the way. Just like a chest, basically, except for you do not have 72 inches, and your kilovolt range is in the 70s rather than the 120. And how do we center an AP thoracic spine? Mid-sagittal plane to the center of the film, and the film's edge is 2 inches above the shoulders. Both arms down in a relaxed position, so the shoulders are at the same transverse plane. Pillow out of the way, knees slightly bent on most patients, shielding. We discussed collimation. It varies from site to site, and if you've done a good job of doing this, your radiograph will show the sternoclavicular joints symmetrical, equal distance, in other words. I have my patient taking a breath, blow their breath out, and then I make the exposure. Then they can breathe, and then I want her to turn up onto her left side, facing that wall. You definitely prefer a left lateral, ladies and gentlemen, because the heart shadow will then be closer to the table. If you're doing a right lateral, the heart would be further away. It would magnify and actually cause a shadow over the thoracic vertebra. So unless there's a pain issue or an injury issue, always choose to do a left lateral. I change cassettes, and I'm going to actually use a left marker now on the anterior wall, ID to the top, some collimation this way. In fact, I'm going to collimate tighter on my lateral on her. She's not very big. And I put the cassette like that. Now I want her straight on the table, and I want the humerus at a 90 degrees, the two hands one on top of the other. Get the humerus at a 90. Don't take it beyond that, because if you take it beyond that, you're going to pull the scapular blade over the thoracic vertebra. You want them at a 90 degrees. That'll tend to keep the scapula away from the thoracic vertebra. And a great idea is to put a sponge between the patient's knees. It's just more comfortable for the patient. The more comfortable they are, the more likely they will not move on you. Just like a chest, you're going to look at the shoulder blades and the small of the waist. Make sure that they are truly lateral. Okay. Once they're lateral, I double check that she's straight, and you can see that I had to make that slight adjustment. Straight on the table, the waist and the shoulder blades 90 degrees. I'm going to need a lead blocker for the posterior aspect of her body. Okay, I haven't positioned that yet. I will in a minute. Now, if you'll remember from your memorization that the film's edge will be 2 inches above the shoulder. With her arms being pulled up, it changed the relationship of the shoulder. So we're actually going to find the cervical prominence. Feel on the back of your neck, and the most prominent bone that's sticking out in the shoulder region, that's the spinous process of C7. That's actually the cervical prominence. That's the shoulder level, and we're going to put the film's edge 2 inches above that point. Okay, that's what you would use. My left marker, actually, the tape didn't hold. You saw where I put it. I won't bother to fix that for the demonstration purposes. Okay, then the mid-axillary line goes to the center of the film. Now I'm tentatively setting things up here. And before I finalize it, I want to look at the vertebral column. And I'm going to find the spinous process. And can you see me palpating here? You won't have to on a real patient because you'll actually have the vision with the gown in mind. And you can see on Jacqueline that there's about a 5 to 10 degree incline of the thoracic spine. Well, I have two choices here. I do not just take the x-ray like this because that spine is not parallel. My two choices are to put a sponge in the small of her waist, and watch what I'm going to do if I were to put a sponge here. See what that spine does? See how it lifts that spine up into a lateral position? Okay. Put a sponge underneath her waist. This tends to be awkward for patients. They're already in pain. So most techs, instead of putting a sponge here, which makes the spine parallel, they will angle the tube cephalic 5 to 10 degrees. I'm going to go about 8 on Jacqueline. I'm going to adjust my SID a little bit. And now I have to, if I have a tube angle, I cannot use the 2 inches above the shoulder because it throws, the tube angle going cephalic will throw the anatomy cephalic. So I'm actually going to put the film's edge about 2.5 inches above her shoulder to compensate for that throwing of the anatomy. And so I set my film's edge, then I get my tube centered to my film, and I'm using the light out here to do that. Okay? Collimation is 17 inches using the gauge, and side to side it's fairly narrow because the thoracic spine is not very wide. Okay, double check that she's still in a true lateral position. Mid-axillary line to the center of the film. It's very posterior. You know, basically it's in the last quadrant. Look at your body. Crosshair should not be midline. It should be to the back wall. And in the case of Jacqueline, I needed about an 8-degree cephalic tube angle. Now, if the spine was parallel, I would not angle. You need to be perpendicular to whatever you're shooting, and that's why making this vision here, checking that patient out, will let you be precise. Okay? And this is a lateral of the T-spine. Look at the tabletop. Now I'm going to show you something else and then we'll be done very shortly. I opened the light a little bit so you could see on the tabletop. This lead blocker is going to protect that film from scatter radiation. Just bring that lead blocker up to the shadow of the body, but because the spinous process is so posterior, I don't want that lead strip into the shadow of the body. I think you can see that. And because I put the lead strip behind the patient, that's why it was necessary for me to put this L marker in the front, or else the lead blocker would have covered it up back here. Okay, Bucky might eat that, so I'm going to remove it and keep it safe. Okay, if I've done a good job of positioning the thoracic spine, again, the film's edge will be 2 inches above the cervical prominence if the tube is in a perpendicular mode. If you're angling cephalic, film's edge is about 2 inches above the shoulders, using the cervical prominence as the shoulder gauge. Patient is in a true lateral position. If I've done a good job of getting them in a true lateral position, the posterior ribs will be superimposed, just like a lateral chest. If the spine is not parallel to the film, or if you fail to angle the tube appropriately, you will have a drum effect, and you do not want the drum effect. the intervertebral disc spaces will not be open. Again, if the spine is parallel, you'll open up the intervertebral disc spaces, no drum effect. And if the patient is in a true lateral position, you'll see the posterior rib superimposed. That's a thoracic spine, AP, and lateral projections.